This talk is about the neurological history. These are the class objectives. You do not need to read them. We will use them to chart our talk. This talk will be conducted using a question and answer format. The first question is: the purpose of taking a neurological history is to generate a hypothesis as to A. Where is the problem? B. What is the problem? C. Why is there a problem? D. How to deal with the problem? A. All of the above. The first question you try to answer during the neurological history is: where is the problem? In the nervous system, the problem can be central or peripheral. If the problem is central, let's say in the brain, then we need to determine if the problem is in the basal ganglia, white matter, or in the cortex, for example. If at this junction we determine that the problem is in the cortex, then we need to further localize the lesion topographically, let's say to the frontal or occipital cortices, but also in the realm of histology to cell type, let's say neuron or microglia, and in the realm of organelles, let's say peroxisome or lysosome. Once localization is established, we need to determine what is the problem. This list uses the word vitamin C to help us remember the different mechanisms producing the neurological findings. This is another list of mechanisms of neurological involvement. This list is from a book titled Neurological Examination Made Easy. I find this list more in tune with the clinical practice of neurology. The next question we must answer is why. So let's say that we arrive to the conclusion that a patient's illness is due to a vascular problem, let's say a stroke. Then we need to know why. Was the stroke due to an embolic material from the heart? Embolic material from the carotid artery? Was the stroke due to thrombosis? Was the thrombus due to dehydration? Or was the thrombus due to arteriosclerosis? The last item we need to attempt to delineate from the history is how to deal with the problem. What test are we going to get? For example, choosing to do an MRI or a CT. If the patient history suggests the patient has a metal plate in the skull, you would get a CT. If the patient is pregnant, you would get an MRI. If the drug of choice for the treatment of meningitis in a patient is penicillin, but the patient is allergic to penicillin, then we need to use an alternative antibiotics. These are few examples where the history will guide treatment or management. So we have to ask ourselves, are the aims of the neurological history and the neurological exam different? The aim is the same, but the weight of their contribution to the care of the patient is different. The contribution of the neurological history to finding where the problem is relatively less than the contribution of the neurological history to what, why, and how. The contribution of the neurological exam to where the problem is relatively more than the contribution of the neurological exam to what, why, and how. Yet, this proportionality will greatly vary according to the temporal characteristics of the neurological complaint. In a patient with fleeting symptoms, such an episode of an arm weakness that has completely resolved by the time the doctor sees the patient, all conclusions regarding where will rest on finding discovered during history taking or on the review of videos recorded during the event. So the answer to this question is E. Next question. The challenges of taking a neurological history are dash A. Symptoms are often not accompanied by signs. B. Neurological structures are usually not accessible to observation, auscultation, or palpation. C. Symptoms are often not remembered by the patient. D. All of the above. Neurological history differs from other medical histories for three reasons. First, neurological complaints are often unaccompanied by observable signs of disease. This is so because neurology often deals with sensory symptoms. Frequent neurological complaints are I see lights, I hear noises, I smell metal, I feel my head is about to explode, and also because symptoms in neurology are often intermittent. Neurologists are often told by patients, yesterday my hand was jerking, but I am fine now. Yesterday I could not move my hand, but I am fine now. The second reason is that neurological structures are, for the most part, not accessible to observation, auscultation, nor palpation. If a patient complains of a sore throat, you can look at the throat. If a patient complains of a headache, you cannot look at the brain. And the third reason is that patients may not remember what actually happened, because mental status may be compromised during the episode and the patient cannot give a good description of what happens to them. They would tell you, I passed out, were you to ask, what were you doing before you passed out? The answer often is, I do not remember what happened. So what can you do to overcome these challenges? Ask friends, ask family, and ask for videos of the event or to video future events. So the answer to this question is D. Next question. Which of the following is true? A. Avoid suggesting to the patient the symptoms that you seek. B. Only ask directive questions that draw out essential points. C. Chart the course of each symptom. D. All of the above. This book is called Principles of Neurology. In the section labeled Taking a Neurological History, we can read the following recommendations, which I like to call them pearls. And there are 6 of them. The first one, avoid suggesting to the patient the symptoms that you seek. I give you an example. This doctor is an autism specialist. A patient comes to him complaining of headache. The doctor asks, do you like to eat the same food all the time? The patient answers yes. The doctor hypothesizes that the patient has autism and spent the rest of the interview looking for other signs of it. Do not do that. Pearl number 2. Only ask directive questions that draw out essential points. Example. The patient comes complaining of headaches. The doctor asks, is the nail of the third finger of your right hand hurting? Bad question. Where, as in the same situation, the doctor asking, is the pain in the back or the front of the head? Is a good question. Third pearl. Find how each symptom progresses. And the key to these sentences is the word each. To explain the meaning of this phrase, I will create a graph to correlate symptom evolution and time. A symptom with 1 to 4 week course is usually referred referred to as acute, one with 2 to 12-month course is usually referred to as subacute, and one with a course of over 12 months is usually referred to as chronic. I will use this chart to give you an example that highlights the importance of analyzing each symptom separately. A 70-year-old man presents with a history of intellectual disability and forgetfulness. If the course of the intellectual disability is chronic and the course of the memory problems is also chronic, then the patient is likely to have Alzheimer's disease. But if instead the patient has a chronic intellectual decline, but memory problems have an acute course, you should consider other diagnoses in addition to Alzheimer's disease. The fourth pearl: determine from the history the degree of disability of each symptom. A patient with Alzheimer's disease, learning issues, that is not learning well, may occur due to intellectual disability, which require a specific type of intervention, or memory problems, which may require a different type of intervention. The fifth pearl: ask the patient to give his or her own interpretation of the possible meaning of their symptoms. Questions like this one, "Can you think why this is happening?" may at times be answered by the patient in this non-helpful fashion. But at times, such questions reveal actionable information. And the last pearl: establish the setting in which the illness occurs, its mode of onset, and progression. I will first talk about the setting in which the illness occurs. A brachial plexus injury in a smoker is likely due to a pancreas tumor. A brachial plexus injury in a neonate is likely due to breast trauma. I will now briefly mention the mode of onset and progression, just to say that it is the mode of onset and progression that determines the illness profile. We will talk much about this later on in this talk. So the answer to this question is D. Next question: which of the following information is more important in the neurological history than in the cardiology history? A. Risk factors. B. Sex, male or female. C. Handedness. D. Occupation. Now I'd like to tell you about another book titled Neurology Examination Made Easy. In the first chapter of this book, you will find a section about the neurological history. The first statement in this section states that the neurological history is the most important part of the neurological evaluation. And it gives 7 steps to gather a good neurological history. I will address each of these steps during the course of this talk. The first step is to gather basic background information. Age is an important consideration in adult medicine, but especially so in pediatrics, because certain diseases are consistently encountered at specific ages. Whether the patient is male or female has marginal importance in neurology, except on rare genetic conditions. Certain occupations are associated with a specific risk factor for different diseases. The most unique of the basic background information to the neurological history is handedness. Why is handedness important in neurology? Well, if you have a right-handed patient, speech will be localized to the left hemisphere in about 100% of cases. If we have a left-handed patient, speech will be localized to the left hemisphere in about 70% of the cases. If we have an ambidextrous person, speech will be localized to the left hemisphere in about 70% of the cases. Why is this important? Because if you are seeing a right-handed patient and the patient has left-sided weakness, you will assume the lesion is in the right cerebral hemisphere. But if in addition the patient has Broca's aphasia, knowing that 100% of the right-handed people have the speech area in the left hemisphere, casts doubt to the right cerebral hemisphere localization. But if you have a right-handed patient with a right hemiparesis, you would assume the lesion is in the left hemisphere. If in addition the patient has Broca's aphasia, knowing that 100% of the right-handed people have a speech area in the left cerebral hemisphere supports your localization of the pathology to the left hemisphere, preferentially to the left middle cerebral artery, as seen in this CT scan and pointed by the arrow. So the answer to this question is C. Next question. When obtaining a neurological history of the present illness, it is better to get an exact description for specific events than an abstracted summary of the typical event. A true, B false. After the basic background information, the next step is to obtain the history of present illness. How do you obtain a history of present illness? By asking open-ended questions like what is going on or what has been happening. Then you listen to the patient's narration. What will happen when you ask open-ended questions? After an open-ended question, you are likely to face one of two situations. The first one is that the patient starts talking and relates a whole story. Try not to interrupt the narrative. The second situation is that the patient does not talk much. In this case, a few kind words or finding commonalities is enough to turn the patient into a storyteller. In general, it is better to get an exact description for specific events, particularly the first, last, and most severe events, rather than an abstracted summary of the typical event. As I stated earlier, it is important that you listen to the patient and let them narrate the story, but if you start getting irrelevant details and the time allotted for the history gathering is coming to an end, redirect the narrative towards useful information. Make sure before you redirect the narrative that you have given the patient enough active listening time and do not attempt to redirect conversation by asking questions such as "What do you mean?" but do so by summarizing your understanding of the conversation that you just had and then let the patient take it from there. So the answer to this question is true. Next question. Which of the following contributes the most to frame the line of questioning while taking history of present illness in a neurological patient? A. Illness profile. B. Chief complaint. C. Genetic factors. D. Risk factors. The patient narrative of the present illness should be squeezed in order to derive from it two deductions. Number one, chief complaint. The chief complaint frames the history. Hence, the nature of the chief complaint has to be clearly established. In Bates, you read that the chief complaint should be stated in the patient's own word. In neurology, I have found this not to be very helpful. Let's say a patient comes to you complaining of dizziness. Writing chief complaint dizziness does not help to determine the nature of the complaint, because the patient complaining of dizziness may actually be referring to vertigo, seizures, or syncope, to list a few possibilities. Hence, you need to probe the patient to find out if by dizziness the patient means a sensation of spinning, in which case the chief complaint should be spinning or vertigo, thus framing the rest of the interview. The second deduction is the illness profile, to which we have previously alluded. The purpose of developing an illness profile is to, based on it, generate an illness profile hypothesis regarding the nature of the process affecting the patient, and to test the just developed hypothesis against other information gathered during the rest of the interview. What constitutes the illness profile hypothesis? As you recall, the last pearl regarding history taking in Principle of Neurology had three components. Establish the setting in which the illness occurred, its mode of onset, and progression. It is mainly with the last two of these elements that an illness profile hypothesis is mainly developed. The illness profile hypothesis equates to a tentative diagnosis arrived at after delineating the illness profile based on historical information. So, the illness profile hypothesis is developed with information regarding mode of onset and progression, also referred to as follow-up course. Under onset, often referred to as mode of onset, I like to consider the temporal relation between the first manifestation of the illness and the precipitating factor when appropriate, the tempo of the illness, that is, the velocity at which the symptoms develop during the onset, and the duration of the onset, that is, the boundary between the onset and the follow-up course, to which we are referring as progression. Under the heading of progression, we should consider evolution, referring to changes of a given symptom over time, and emergence, that relates to the appearance of a new symptom or symptoms. So the answer to this question is B. Next question. The duration of the onset of an illness begins with the first symptom or symptoms and ends when dash. A. Improvement, stabilization, or exponential acceleration of the initial symptom occurs. B. An additional symptom appears. C. Initial symptoms decouple. D. All of the above. We saw this diagram in the process of answering the last question. As you know, one of the factors that determines the illness profile is the mode of onset of the illness, which has three components: the temporal relation between precipitating events and the first symptom. I will give you an example. Weakness coinciding with the beginning of a flu probably indicates viral myalgia. Weakness starting 1 week after resolution of flu symptoms is likely to indicate Guillain-Barré syndrome or viral myositis. Tempo refers to a speed of evolution of the finding during the period of time defined as onset of the illness. A patient with a history of progressive generalized weakness for 24 hours that is able to get up from sitting position despite the weakness is more likely to have a viral myositis than Guillain-Barré syndrome, whereas a patient with a history of generalized weakness that after 24 hours cannot get up from bed because of weakness is more likely to have Guillain-Barré syndrome than a viral myositis. The third factor contributing to establishing the mode of onset is duration. Determining the duration of onset of illness, that is establishing the temporal boundary between the onset of an illness and the follow-up course, is more difficult, imprecise, and lacks consensus among neurologists. In the next few frames, I will put forward guidelines I have found useful. In order to establish the duration of the onset of an illness, we need to take into account two different clinical situations. The first situation is when an illness debuts with a single symptom. In such situation, the onset starts with the initiation of the symptom. The onset period ends when there is a change in tempo, such as exponential worsening, which usually indicates decompensation, improvement, resolution, or stabilization, or when a new related finding appears. The second situation we may encounter is when an illness debuts with multiple symptoms simultaneously. In such cases, onset starts with the initial symptom and ends when one of the symptoms decouple from the other, when a new symptom related to the disease appears, or when there is a changing tempo as previously mentioned. So the answer to this question is D. Next question. Which of the following conditions usually has a shorter onset of illness? A. Seizure, B. Stroke, C. Migraine, D. Meningitis. In the process of answering this question, I will provide you with some examples that reflect the benefit of defining onset of illness as we have just done. In this frame, we will populate a table correlating onset of illness of different types of pathological processes. So here I am placing the word onset to be the head of a column, which expresses time in seconds to years, and the word process to be the head of a row. In this row, I will enumerate likely pathological processes that produce neurological symptoms. I will start with vascular. Vascular pathology has a binary pattern of onset. Most vascular symptoms reach maximal expression in a matter of seconds to a minute. Seldom neurological symptoms of vascular disease reach maximal expression in hours. But some symptoms that occur due to secondary effect of vascular pathology, like weakness due to cerebral hemisphere compression following accumulation of blood in the subdural space, may reach maximal expression in a matter of weeks or days. When symptoms are the result of epilepsy, most of the time maximal clinical expression is reached in 1 or 2 seconds, and only rarely the maximal expression occurs in minutes. Recall that whereas patients with syncope fall slow enough to attempt to break the fall, patients with epilepsy fall suddenly and do not have time to break the fall. Symptoms of migraine seldom reach maximal expression in less than a minute. Most migraine-related symptoms reach maximal expression in a matter of 10 to 20 minutes. Seldom maximal expression is reached in 1 or 2 hours. Neurological symptoms produced by inflammation, like lupus or multiple sclerosis, usually reach maximal expression in a few days. Neurological symptoms of infectious processes have the same onset mode. Symptoms due to neoplasm most of the time reach maximal expression in a matter of 2-6 months, seldom in a matter of days, rarely over a 1-year period. Symptoms of degenerative diseases usually reach maximal expression in a matter of years. Symptoms of genetic conditions also usually reach maximal expression in a matter of years. Symptoms of congenital diseases are present from birth. So the answer to this question is A. Next question. A 50-year-old man with complete visual loss of the right eye that came on over 10 minutes. Most likely cause A. Seizure, B. Stroke, C. Migraine, D. Tumor. A 50-year-old man presents with complete visual loss in the right eye. If the visual loss came on suddenly in less than a minute, we are most likely dealing with impaired blood flow to the retina. If the loss of vision came over 10 minutes, most likely we're dealing with migraine. If symptoms come on over 4 days, we are most likely dealing with an inflammatory process like optic neuritis. If it has come over 3 months, we are most likely dealing with a tumor. So the answer to this question is C. Next question. A 65-year-old woman with left-sided face, arm, and leg weakness that came on over 4 months, most likely cause A. Subdural bleed, B. Stroke, C. Migraine, D. Tumor. A 65-year-old woman with left-sided face, arm, and leg weakness that came on suddenly in less than 1 minute, the odds are we are dealing with a vascular event. If weakness came on over 10 minutes, again, vascular disease is most likely. If came over 4 weeks, we must consider the possibility of subdural bleed. If came on over 4 months, the most likely pathology is tumor. If it has began and been present since birth, then the most likely pathology is congenital. So the answer to this question is D. Next question. The time course of the initial manifestation, onset of an illness, gathered while history taking always corresponds to a specific pathology. A. True, B. False. Medicine is like English grammar. There are too many exceptions. Why do I say this? Because vascular, inflammatory, infective, neoplastic, degenerative, genetic, and even congenital conditions, first manifestation may be a seizure. Seizures are the hallmark of epilepsy. So the answer to this question is B. Next question. The mode of onset of an illness can only be determined after dash. A. The initial symptom changes tempo. B. A new symptom appears. C. One of the simultaneously initial symptoms tempos decouple. D. All of the above. Although it is stating the obvious, it is important to be aware that it is not always possible to know the mode of onset of a condition when we see a patient for the first time, even if historical information is available, because the evolution of an illness is not known at the time of the visit. In the next frame, I will introduce a table about the causes of infant macrocephaly to expand on this point. In this table, you can see a list of the most relevant conditions producing macrocephaly during infancy. Most require timely intervention, but are infrequent, encountered especially in infants with macrocephaly without signs of encephalopathy, focal neurological finding or dysmorphism. Few, the one just turned magenta, only requires observation but are frequent in the previously described clinical setting. Hence, in cases of infant macrocephaly, establishing the end and evolution of the beginning, that is, the mode of onset, may be tricky and not always possible. Let's say you see a patient with macrocephaly at 6 months of age with the pattern of head growth corresponding to the blue line introduced in this frame. You do not know if in 4 months the head will grow 3 centimeters, suggesting that the head growth during the first 6 months was due to benign enlargement of subarachnoid spaces, a condition also called benign hydrocephaly of infancy, or instead, 4 months later, it had grown 11 centimeters, suggesting that the head growth during the first 6 months was due to obstructive hydrocephalus, most likely due to congenital malformation or subdurals. Or instead, 1 month later, after you see the patient will develop diplopia due to third cranial nerve dysfunction, suggesting that the head growth during the first 6 months of age was due to obstructive hydrocephalus caused by a posterior fossa tumor. So the answer to this question is D. Next question. In the course of taking a history, you discover that a 3-year-old child had pathological head circumference increase since 2 months of age and developed galloping strabism at 6 months of age. Which is the likely cause of macrocephaly? A. Genetic condition, aqueductal stenosis. B. Infectious condition, ventriculitis. C. Neoplastic process, astrocytoma. D. Inflammatory process, multiple sclerosis. The course of this illness presented in this question can be charted as such. This allows to conclude that since diplopia appeared at 6 months and macrocephaly at 2 months, the onset of illness is 4 months, thus suggesting a neoplastic process and not a genetic condition such as aqueductal stenosis, despite the course of the macrocephaly. So the answer to this question is C. Next question. The evolution of the initial symptom or symptoms always correlates with a single pathological process. A true, B false. Going back to illness profile, we have already considered onset of illness. I will now address illness progression. Illness progression can be easily defined as what occurs after the onset of illness. Progression can be considered from the perspective of evolution of a symptom. I will now introduce different modes of evolution and indicate the pathological process or processes they suggest. In this chart, you can see represented onset of illness, and I now will introduce progression of illness as expressed by evolution, that is, as expressed by the changes of the initial symptom or symptoms over time. A symptom can recede over a significant amount of time, as represented here. This pattern of evolution occurs with, for example, in patients presenting with numbness due to stroke, but can also be seen if numbness is due to sustained or severe nerve compression. In other cases, progression can recede over a short period of time. This mode of evolution can be seen with numbness after a transient ischemic attack or numbness following a brief nerve compression. The progression can also be remitting and relapsing with complete resolution between episodes. This mode of evolution can be seen with repetitive nerve compression or in patients with MS. Remitting and relapsing evolution can also occur with only partial resolution between episodes, as can be seen in numbness due to MS or frequent repetitive nerve compressions. Evolution can also be expressed by stabilization, as it would occur with numbness following permanent nerve damage or permanent brain damage. Another possible mode of evolution is for a symptom after a period of stability to worsen, as can occur with numbness due to slow-growing tumors in the central or peripheral nervous system. The slow growth allows the tissue surrounding the tumor to adapt for a while, thus producing a period of stabilization. But with subsequent tumor growth, the surrounding tissue can no longer adapt and the deficit worsens. So the answer to this question is B. Next question. Which of the following can be the cause for the appearance of a new manifestation related to an ongoing neurological illness? A. Expansion of the involved area. B. Release phenomenon. C. Aberrant reinnervation. D. All of the above. The second component of progression is emergence of new symptoms. In neurology, new symptoms appear due to expansion of an involved area. This photograph depicts expansion of involved area by pathological process. This condition is called Perry-Romberg syndrome. As you can see, eye abnormalities were not present initially. This occurrence indicates deterioration of illness. A new symptom can also appear due to release phenomenon. The classic example can be seen following severe spinal trauma. The patient initially develops flaccid paralysis. Weeks or months later, the patient develops spastic paralysis and upper motor neuron signs. New symptoms can also appear due to aberrant reinnervation. The classic presentation is the appearance of crocodile tears following Bell's palsy, or the appearance of synkinesis. Notice that early in the course of the palsy, during gentle contraction of facial muscles, the right eye remains open, whereas 1 year later it closes, indicating clinical improvement. Now notice what happens early on during a stronger contraction of the lower facial muscle. The right eye does not close, whereas later on, with a strong contraction of the lower face, the right eye closes, denoting an aberrant reinnervation of the orbicularis oculi by fibers meant to innervate the lower right facial area. So the answer to this question is D. Next question. Neurological screening questions should include questions about A. Job and school problems, B. Nausea and vomiting, C. Psychological changes, D. All of the above. The third step in order to obtain a good neurological history suggested in the book Neurological Examination Made Easy is to ask about frequent neurological symptoms. Here I have listed some of the suggested questions. You may stop the video and read them. So the answer to this question is D. Next question. Which of the following conditions is a patient with a history of progressively needing larger size gloves and shoes likely to have? A. Is Sjogren's syndrome. D. Olfactory groove meningioma. C. Dysautonomia. D. Pituitary tumor. I also like to include in the neurological screening questions a neurologically targeted review of systems. In the next few minutes, I will provide you with a list of relevant items to query. By the side, in parentheses, you will find the main neurological reason for these questions. Please read them as I mention each item. In the general section, I like to ask about weight loss, energy level, and about the presence of chills and fever. Ask about head trauma, about the eyes, ask about visual loss issues, episodic and progressive visual loss, double vision, ptosis, dry eye, photosensitivity, and eye pain. After eye questions, we ask nose questions about anosmia and discharge. Remember, if a patient tells you that the mucus is sweet, the patient is having a CSF leak. After the nose, we ask about the mouth. Is the tongue sore? Is the tongue dry? After the mouth, we ask about neck issues, about the presence of pain, about the presence of stiffness. After the neck, we ask about the heart, ask about the heart diseases in general, hypertension, and specifically about cardiac arrhythmia. After the heart, we ask about the lungs, ask about dyspnea, asthma, and tuberculosis. After the lungs, we must think GI, changes in appetite, excessive thirst, constipation, vomiting, and hepatitis. After GI, we go to GU. We ask about urinary incontinence, urinary retention, impotence, polyuria, spontaneous abortions in women, sexually transmitted diseases, and pigmenturia. After GU, in a woman, we should ask about menstrual history, ask about the use of oral contraceptives, and hormone replacement therapy. After menstrual history, we need to ask about endocrine issues in men and women. We need to ask about galactorrhea, amenorrhea in women, history of enlarging hand and feet, and thyroid disease. After endocrine, we should think musculoskeletal problems, ask about arthritis, muscle cramps, and about myalgia. After asking about musculoskeletal problems, we should ask about skin problems, history of rashes, insect bites, and birthmarks. So the answer to this question is D. Next question. The setting in which an illness occurs or risk factors should be sought during the process of obtaining a neurological history. A true, B false. After neurological screening questions, we should inquire about past medical history, drug history, family history, and social history. This is done much in the same way as it is done for the general history. And the findings are primarily used in conjunction with the background information to determine risk factors. So the answer to this question is A. The hypothesis as to the nature of the process producing an illness arrived at following the neurological history is firmly based on onset illness mode. A true, B false. In this screen, you can see a flow diagram. It starts with illness onset mode, which is the most important contributor to determining the nature of a process in most occasions. The information yielded by the onset mode is used to develop a hypothesis. The illness progression is then used to reject or support the previously created hypothesis. The weight given to illness progression findings varies depending on the initial hypothesis and the progression of illness found, but as previously stated, the onset of illness is more reliable to determine the most likely pathological processes involved than the conclusion arrived based on illness progression. When the initial hypothesis based on the onset of illness is supported by the course of illness progression, the newly confirmed hypothesis corresponds to the illness profile hypothesis. Then the information obtained from basic information, screening neurological questions, and risk factor is used to formulate a historical differential diagnosis. The historical differential diagnosis consists of 3 to 5 most likely illnesses producing the patient's symptoms. So the answer to this question is B. Next question. Which of the following line of questioning is most appropriate for a patient with headache? Please take a look at these diagrams. Look at all the different items indicated by the line emanating from the oval structure and then choose the correct answer. Although so far we have talked about history in general, specific conditions require, in addition to the usual questions about onset, frequency, duration, and precipitating factor, specific questions. Patients with visual disorders should be queried about extent of impairment, diplopia, hallucinations, and illusions. When evaluating a patient with loss of consciousness, your query should include tongue biting, incontinence, and limb twitching, alcohol and drug abuse, head injury, and the presence of cardiovascular or respiratory symptoms. When evaluating a patient with headache, you should ask about timing, severity, character, relieving factors, site of involvement, and associated features. When taking a history of a patient with a motor disorder, you should ask about coordination, type of weakness, and whether it is progressive or static, distal or proximal, painful or painless, about involuntary movements, and about relieving factors. When seeing a patient with speech and language disorders, you should ask about difficulty with repetition, articulation, expression, and understanding. When taking a history of a patient with sensory disorder, you should ask about pain, numbness and tingling, site of involvement, relieving factors. The history of a patient with mental disorder should include details about memory, intelligence, personality, and behavior. Often, this information must be gathered from family and friends and caretakers. When taking the history in a patient with sphincter disorder, it is important to ask about bladder if the patient comes with anal complaints, and about anal problems if the patient comes with bladder complaints. It is also important to query if the problem is with incontinence or retention, the history of a patient with lower cranial nerve disorders should detail about deafness and tinnitus, vertigo, balance and staggering, swallowing, and changes in voice. So the answer to this question is B. Thank you very much for your attention.